Hey everyone, this is Victor from Cyborg for Life, and in today's special interview, we're continuing our Surgeons on Stride series as I'm joined by Dr. Kevin Debiparshad of the LimbplastX Institute in Las Vegas, Nevada. Now, Dr. D is going to give his take on the current situation of the Precice Stryde being removed by NuVasive to do some additional testing. And so, please enjoy the interview with Dr. Debiparshad. Hey everyone, this is Victor from Cyborg for Life, and today I am joined by Dr. Kevin Debiparshad of the LimbplastX Institute in Las Vegas, Nevada. Hey Dr. D, how are you doing today?
Good, how are you, Victor?
Doing great, doing great.
I'm
Thanks for joining me for the last video of the Surgeons on Stride series. So Dr. D, I want to bring you on to get your perspective of the recent removal of the Precice Stryde lengthening nail. I know a lot of patients recently had to either cancel or reschedule their procedures because NuVasive wanted to do more testing on the Stryde nail to ensure its safety and to prove to regulatory bodies that it was safe. So I wanted to get your take on the whole situation about the Stryde nail removal.
Okay, so yeah, so there was a, so it's not, I guess, officially a recall. I guess it's a voluntary sort of field safety notice that was issued for two things, actually. So the first thing was for Precice 2.2, and so I've had a lot of questions about that as well. I don't know if a lot of people have been talking about it, but one of the things that was in the field safety notice was that obviously Precice 2.2 is not, officially certified to be used in pediatrics, so in patients below the age of 18. Okay. So just to clarify, it never was. So to be honest, we've been using Precice and these types of technologies. The largest market for it is still for congenital deformities, as you imagine, children that are born with congenital defects. So that's still the largest market in the sense of the patients who are getting these types of procedures to correct deformities and discrepancies, and that's sort of stuff. And it has been used for over a decade in that field. To do that, it's just been used as an off-label use. But most of the data that we've collected on it probably has been in patients below the age of 18, because that's where we use it the most. Yeah. So that's one thing that was issued in the field safety notice. It was more of a reminder to say, this isn't actually approved for people below the age of 18. So the first thing that NuVasive is going to go ahead and do is certainly go ahead and get all that information so that it can be approved for that population. Doesn't mean it still can't be used in that population, because nothing has changed. Mm-hmm. It was never approved in the pediatric population. So I did have younger patients below the age of 18, and one particular patient that I talked to recently who was looking at more from a cosmetic perspective, and their parents, and they were worried about that because that was one of the things that was issued, and their parent was a doctor, so they looked at the field safety notice, and that was one of the things that was noticed. So just to clarify, it had always been not, certified for pediatrics. However, it was, used in pediatrics. So the first, part of that is we're going to go ahead for Precice 2.2 and go ahead and get that certification so that it can be used in the pediatric population. The second component was obviously pertaining to the Biodur type products, which is a form of stainless steel. So those implants, including the Precice plate, transport nail, anything that's made out of this Stryde nail, have been paused and are no longer going to be used out in the field until there's sort of further notice about what changes are happening in these implants and what are the implications in that. So just to clarify, so Biodur is a type of stainless steel. So a lot of stainless steel is very routinely used. It's actually the first type of metal that we've actually we've been using in the body. I think the first implant was like back in the 1920s or something like that. So over 100 years that we're putting stainless steel in people, and we've constantly been trying to improve stainless steel in some ways. We've gone from like 316 stainless steel to 316L, which has slightly lower carbon, that has better wear characteristics, and then looking at even Biodur, which is basically the same type of stainless steel. However, it's devoid of nickel, so it's very nickel poor, and it's replaced with nitrogen. So the type of metal that's used for these types of devices is Biodur 108, and that type actually has very favorable characteristics when you look at it. So if you actually look at Biodur 108, it actually has very good characteristics from a corrosion perspective. So it actually corrodes less so than stainless steel 316. It has stronger, it's physically stronger, and the other benefit, especially with this type of technology, is that it's not ferromagnetic. So it doesn't magnetize. So for a magnetic type device, which Stryde is, it tends to be a perfect selection type of material for this type of technology. So I don't want to bore people with too much of the components of it, but that's kind of what we're sort of talking about. And it's a newer type of stainless steel, but we're seeing some changes in some of the explants, and so those are being further investigated by the surgeons who put these in, as well as the company itself.
Great. Yeah, and I actually wanted to kind of dive into that a little bit, because we mentioned earlier about the corrosion of, you said, Biodur, which is what the Stryde nail is made up of. And for you as a surgeon, I'm sure you've been implanting the Stryde nails. I wanted to kind of get your take on, have you seen any of this corrosion, and can you give your take on like what's really going on there?
So a lot of patients have asked about it, obviously, since the field safety notice have been issued. So one thing, patients ask me, how is my leg rusting and that sort of stuff. So just to clarify, it's not rust. Rust is specifically iron oxide, which is the oxidation of iron itself. So when you see iron and rust, like iron chain, you can see it kind of degrade, it flakes off and it breaks. So it's not rust itself, but there is some changes that we do see. So right off the bat, all stainless steel changes. So any metal alloy you put in the body, anything you put in the body is going to change. So that's the key concept.
Okay.
God didn't put it, nature didn't put it there, whatever you want to believe in, and there's going to be some effect to both the implant itself and to the body surrounding it. Okay. The question is, how compatible is that thing? So, for instance, not just in orthopedics, like for instance, if you look at stents that they put in hearts, so these are the arteries that loop around the heart, those are made of stainless steel. A lot of those are made of stainless steel. You're like literally putting them around the arteries that surrounds one of the most important organs in your body. And a lot of orthopedic implants are made of, three common alloys, which are titanium, cobalt chrome, as well as stainless steel. So those are the three most common that we've been using. Obviously, Precice 2.2 is a titanium type implant. It, by its nature, has much better corrosion type properties. The reason they discovered this is back in the 1940s. They noticed that when airplanes and stuff crashed and fell into the sea or the ocean is very harsh, like our body. It's full of salt water, and they realized these things didn't corrode. And they thought, oh, wow, that's amazing. Titanium didn't corrode. So they started implanting titanium into the body and realized that it does have favorable characteristics from a corrosion perspective. However, there are other characteristics of titanium that are less desirable, like it's not as strong as stainless steel, and there's some other characteristics from failure that you could look at that are not as good as stainless steel. So those are things that you have to kind of balance out when picking a specific type of metal to use for an implant. So it's really just kind of looking at the characteristics of the metal and seeing what would work best for that particular indication. So just to keep that in mind. So I agree with, a lot of people have been saying, all implants change and all implants, corrode to some degree, and that is true. Nothing is perfectly meant to be in the body, and the body is a very hostile environment. It's like, it's warm, it's full of like salts, it's full of proteins, it's full of all this other stuff. So it's not a very friendly environment to be in. So that's why we look at these biocompatible studies. And what we want to know is, with any implant we put in the body, what happens to the implant? So that's the key thing. So one of the things we want to know is what happens to the implant. Okay. The second thing, what happens to the local tissue near the implant? And the third thing is, what happens systemically, meaning that are there any implications through things that are far away from the implant itself, like organs or what they mean. So those are the three questions that we want to always answer when placing any type of implant. If it's a plate with screws, if it's a total hip replacement or knee replacement, if it's an intramedullary device that lengthens bone, if it's a pacemaker, if it's a stent, all these things will have some component of breakdown and changes to the local tissue, potentially systemically, as well as to the material itself. So those are really the key things we're looking at, and that's what we're doing now. As we see some changes and as we see some differences in this metal, we want to know exactly what's going on, so that we can best advise and decide on what to do next.
So should patients who have this implant in them now, should they be worried about it? Have you, as a surgeon, seen any implications of the type of, effect that it has on the tissue that's surrounding the implant?
So that's a very good question. So when I look at the data clinically, and so we were one of the sites, there was 3 American sites and 1 overseas sites that I think had high volume of Stryde, and we all collectively submitted our data to NuVasive. We stopped collecting sometime last year. I think we submitted 116 implants, which I think was probably the second highest volume to NuVasive for retrospective analysis. And it takes a lot of time because you have to go back and look at the x-rays and the clinical data and that sort of stuff. And overall, what I tell patients is that I wouldn't worry. So one thing I would say is, if you're asking me, does Stryde accomplish what it's supposed to accomplish? The answer to that is yes.
Okay.
It lengthens bone. It certainly makes, creates great regenerate. It certainly allows weight bearing, and it certainly accomplishes what it is supposed to do.
Okay.
So I don't see any clinical implications in the sense of I've not had any patients had a fracture. I've not had any patients have any sort of pain, particularly around, some of these areas where we are seeing some of the bony changes. And those bony changes may be just that, bony changes that are there that have no clinical implication.
Okay.
But we're scientists, and it so fascinates us, right? I mean, like yourself, a master's degree and your background, I mean, it fascinates us to see what these changes are. And it is intriguing to kind of look and delve a little deeper, try to figure out why these changes are happening, and can there be something that can be done to, to rectify that or change that, even though ultimately maybe it doesn't matter. Because we have clearly seen, even looking at what data we presented, that the nail certainly accomplishes what it's supposed to accomplish. It gets through all the phases it's supposed to get to, and eventually it should be removed. And as we've always advocated, at some point the implant should be taken out. But it is interesting to know that there are some bony changes there, that we are seeing, and it's not a very high quantity that we're seeing, but there are some changes there that we are seeing, and they may be clinically not important, but they are happening, and we want to sort of be able to understand why they are occurring. So let me show you kind of what we're talking about. So I have I'm going to try to do this share screen thing here. Let me just give me a second.
Absolutely.
See if I can pull my, you know what, let me do this first. So let me pull this one, and let me try with this one first. And I apologize.
You're good.
Yeah. Okay. So here are some of the things that we are noticing. Okay. So can you see that? Okay.
Yep.
Let me just move it over there. Okay. Okay. So when we explant some of these devices, there are clearly some wear characteristics that we're seeing, and so this is what we're talking about. This kind of and some of this may be some dry blood over there, but there are some corrosive changes that are happening at that female-male junction. So that's where that telescopic device is actually lengthening out. So as you lengthen a millimeter, that is kind of slowly telescoping out of that area. Okay. And we are seeing some changes that we'll label as some kind of corrosive changes at that interface. So that's what we're talking about and what we're seeing when we explant the device. Now, whether this is clinically important or not, it may not be. It may still, not cause any discomfort, not cause any pain, not cause any, long-term effects, and eventually the implant comes out. But this is what we're seeing from that perspective. And this is one that I had explanted not that long ago. Now, I'm going to not stop sharing this one, and I'm going to pull up another one. The theory, at least, is that, can you see that? So now there's some dry blood on this. Obviously, I just explained this out, so it's not fully. But one of the things that we notice is certainly some changes around that interface again, as you can see. But you can also see that there's some changes even around the screw holes. Yeah. So what I think is going on is that there's different types of corrosion that happens, and there's a particular type of corrosion called Crevice corrosion that can happen when there is a small microenvironment that is locked away. So you can imagine that it's kind of like if you think about like a penny. Have you ever found a penny that's been sitting on the ground for 10 years, and you flip it up and realize one side of it's all rusted and the top coat is normal? Right. So what actually happens is between that penny and the ground, there's actually a little bit of space in between there, and it creates a microenvironment, which is like a crevice environment. And that crevice environment can be completely different than the environment that it's seeing on the top of that penny. And it's actually through that you can have accelerated changes in corrosion. Okay. And what I've noticed is that when I look at these explants, the changes both at the bone level and on the implants seem to be really at this interface here, which you can see, and at that interface where the screws, which are made of the same material, that go through the distal locking screws. So I'm thinking that there may be some small change that is happening there, that there is a little microenvironment that is developing, that and there may be more play also with the distal screws, and that's why there's some maybe potential contact between that distal screw and that screw hole that allows the corrosive changes to maybe slightly be accelerated. Okay. So that makes sense. Yeah, definitely. And so at the junction of the male and female part, whether that's mechanically strained and mechanically changed at all, that may be part of it. But I also think that you can imagine that between that male and female part, it's not perfectly sealed in some ways. There is probably some small amount of space that can be there. So you imagine body fluids getting in there, and different types of solutions, basically like a saline mix, getting trapped in that area, and that area continues to kind of break down and evolve, but it's very independent of what the rest of the nail is seeing because it's stuck in this little crevice.
Right.
And that's where. So I think if this was a fully solid implant, it would be very different. Meaning that, if these didn't exist, like if you just had a piece of Biodur just stuck in your arm that didn't have anything in contact with it or anything like that, like most of the preliminary data has shown about Biodur, it probably has better corrosion characteristics than does traditional surgical stainless steel.
Wow.
Because that's kind of what we've been saying. So it's of interest to us to see that that there is some changes that we are seeing on both clinically when we take the implants out, as well as there are some radiographic changes that we are seeing. So to that effect, yes, I have seen some of these changes. I've also seen I'm going to stop sharing this for a second, and then I have certainly seen some of those changes. Certainly in explants. And I've not noticed, though, that there's any clinical implication. So I think that's important because we're dealing with clinical medicine. And I've not noticed that there's, some patients that I see some changes. And I can show an example. I don't want to take too much time here, but I can show you an example of a patient that, let me see if I can pull this one up. Let me pull this over and then share the screen again. And okay, so I'm going to pull this one up here. So I haven't seen very many of these so-called lucencies. So let me show you this here. So this is a Stryde patient. I believe he accomplished nearly the full length, did very well. He was actually had his femurs and tibias lengthened. So the femur was done first initially. But some things that you see is, and what we're all talking about is this. So do you see this change here? This lucency that's right around that area. And you can also see this hypertrophic type change that's happening. So let me differentiate that from what you see up here. This is the regenerate, which has healed. And you can see that that's hypertrophic and it's kind of healed. And so that's not a big problem, right? I mean, obviously that's normal. We've seen that in external fixators. We've seen that in, the Precice. We've seen that in all other things. That doesn't seem to be an issue. We're not so worried about the hypertrophy around the actual regenerate itself. However, where I see the hypertrophy in my analysis is really at this point here. And here we're seeing hypertrophy as well as this lysis. I don't know if you can see that very well, but you see this like kind of lysis. So that's the part where we know that something is changing at this interface, whether it's crevice erosion, and there is some kind of particulate matter being produced here that is causing the bone to change because the bone is reacting to the chemical process that's happening. Now, again, this may have no clinical implication. This is you and I, your master's in this type of field, and it's of interest to me as well. So this is us looking back and trying to see, hey, this is something we've noticed. Why is it happening? Does it really matter, or does it not matter at all? But that's one of the things. Another area where I see changes are, and I think that some of the other surgeons maybe might echo the same thing, is around these distal screws. And I kind of showed you that explant where I saw some corrosion changes around the screw itself. And I think that the same, accelerated or changes in corrosion that are happening here as well. And initially, let me stop sharing this screen for a second and show you patient where I actually took that implant out. It had no symptoms at all. He had no pain, very well, no symptoms at all. So here's me taking the implant out, right? So what do we see? So these are the screw holes that we see here. Those will disappear after some time, generally, anywhere between 9 to 12 months, as what some of the data will show for those kind of go on. So those are not too bad. And I'll show you something about his right side in a second. But one thing I will show you, that this hypertrophy that people are talking about, I still think related to the chemical changes that are happening at the level, because I have some patients where you don't see this clear lucency line, but what you do see is endosteal scalloping. So if you look at the inner part of the bone, you see how it like carves out. Now, some of that is because the fact that this part of the nail is thicker, obviously, and this part is thinner, but there is some reaction that's happening. You can almost tell that there's something happening. It looks like a circle here. Can you see that?
I can see
like
that.
How this the inner aspect is like kind of worn away a little bit. So I think even in the cases which are much more common, where we're seeing hypertrophy at that interface, I think it's the exact same process going on. What I had originally And I'll show you what I mean when I look at. I'll show you his right side, this patient's right side. But I think that whatever is happening in that segment is not only the bone is basically reacting to it. It's seeing these changes and this corrosion, residue that's coming from this area, and the bone is responding to it.
Okay.
And how it responds is that either some will break down and you will see that lucency, which is more rare to just see a full lucency. I will say that I've probably seen that extraordinarily rarely, maybe in 2% of cases or less, in the 116 implants that I've looked at and that I've collected since sometime last year or something that we've implanted. But I think the same process is going on. I think the key is that on X-ray you may see lysis versus hypertrophy, but I think it's the exact same process, meaning that I think whatever is being created causes the bone to react, and the bone reacts by it. Initially is having the inner aspect of the bone worn away by this process. So what does the bone do? It has more bone on the exterior.
Okay.
And it responds by hypertrophy. But I do think that this reaction is due to that. Now, the other thing that we've seen, and I'm going to show you his right side. Let me just unshare this out as well. But so if you look at his right side, and here I put it up here.
Yeah.
So one of the things you see, and we've seen this a lot, is again, you don't see that lucency necessarily, right?
No.
You don't, right? So if I, quiz you on this and say, "Oh, you see anything? What do you see?" What you would tell me, you say, "Hey, doc, I see this hypertrophy here."
Right. Yeah.
And what you see here is I see this hypertrophy here.
Yeah.
Right. You see that kind of bone that kind of envelops over the area. So what I thought was initially when I started looking at this, and I would see the hypertrophy very commonly, particularly around the distal screws, and I thought, wow, it's because they're weight bearing, and it's because there's a massive amount of force that's going through these, right? These nails can generate, the largest 13 millimeter nail can generate like 300, 400 pounds of force that's being concentrated at this distal segment, right?
Right.
But I don't think that's the case. I actually think that the micromotion or the nanomotion that happens between the metal, between this interface, between the actual screw and this is the exact same process that's happening here.
Okay.
So I always thought that this was related to mechanics. I thought it was all mechanical, and it was just hypertrophying because it was seeing more stress, it was seeing more load, it was, like that, just the principle of bone, right? But I actually now I'm wondering if it's chemical in nature.
Okay.
And I wonder if that this property that I observe on some of these distal screws, these changes in that is basically doing the exact same thing it's doing up here, right? Because this is. And why is this hypertrophy? Because of what's happening at this segment here. Now, if you look very closely at this image, remember I talked about how there might be endosteal scalloping. What's this?
Yeah, a little bit of that. Yeah.
You see how this this black line is here? So because this patient doesn't have that lucency that you would say, oh, that's lytic, or that one I see the lucency there, I still think it's the same process. I just think that this side happened to make more bone around it, and so you aren't able to visibly see it. But if you look carefully at the inner canal, you can actually see that process is probably what is creating all of this, right? Creating this, you can actually see it. And in fact, I have a picture of him where I take the nail out. So let me stop sharing that 1 second. So look at this. This is me. This is the same patient. I took out the right side, and you can see that hypertrophy that was there. So initially I was thought this is probably mechanical. Makes it a little tougher to take the screws out, but I actually don't think that that's the case. I think that same process that's creating this amount of bone here. So if you look at the image itself, this is the regenerate. That's the hypertrophy we saw.
Right.
Okay. Then it sort of flattens out where we expect it to. But then we see this hypertrophy here. Correct? And that hypertrophy, if you look very closely, it almost looks like there's an inner little circle here. See that? Exactly where that interface is, where that male and female is, that junction is. And I think that corrosion that happens there is still affecting this inner cortex of the bone. Okay. And as a reaction, the bone makes more bone.
Okay.
Right. So I think in a lot of patients, we just see this. Okay. But what we're missing is that the inner aspect of that bone, there probably is some changes that are there that are slowly kind of wearing out that area. And that is what's creating this issue. Now, if I extrapolate, I think that's what's occurring because I see some corrosion at these disc screws, like I showed you in the picture. Yeah. I think that process may be what's amplifying this.
I see. Okay.
Right? see this hypertrophy of these distal screws, and I think, oh wow, these guys are just really good at making bone, and like it's so much force and talking, and it's so great. And then I started thinking, like, well, but I am seeing some changes at that screw hole. Not all the time, but I do see it sometimes. And I wonder, is that process just like up here, the same process where there's a minor amount of corrosion that's happening there, and the bone is basically just doing the same thing, because it's not just mechanical. The fact that the bone just keeps developing because it's responding to what's ever happening at that interface.
Right. That is.
So that's what I've been, that's what I've been noticing. And at first I thought some of it was mechanical changes, but the more I've looked at these images and I've kind of looked at some of the explants and looked at some of the things, I think, this is my sort of running theory that, maybe some of this crevice erosion that's happening at those two interfaces is what is causing this. Now, that's all fun and stuff, and we can talk about it and debate about it and argue about it and, do all kinds of fun stuff. Right. It may be irrelevant, right? But that's the other thing, right? I can be doing this and like racking my head and looking at X-rays all day and looking at explants and sending them back to NuVasive to analyze. And at the end of the day, maybe it isn't because maybe it doesn't change anything clinically. Yeah. Okay? So maybe it still does do. And I'll stop sharing the screen so we can kind of get that. So maybe, but what we want to know, right? We want to know. We've noticed these little changes, and we've noticed as, we've kind of come onto the 2.5 years or 3 years of using this implant, that as we take these implants out, we've noticed some changes there. It's a different implant. I mean, it's a different implant in the sense that it's an implant that moves, and it's an implant that has a very strong magnet in it. And I think that one of those two things probably have to do with why we probably see some of these corrosion changes. Because if you look at the Precice now with 2.2, remember I told you titanium has a very good corrosion protocol. It doesn't corrode it. It's very good. It's very good. So, we don't necessarily see these types of changes with the Precice 2.2 necessarily. And even when we take them out, it doesn't tend to have these types of changes when we explant them. So I think, that's certainly the difference in that sense. I think that as we look at this more and more, we'll kind of be able to kind of figure it out and decide whether or not is it an issue or is it not really an issue. Looking at it just overall clinically, seeing patients go from point A to point Z, I certainly don't see anything. I mean, I certainly think that patients clinically do, very well with it. I still think patients do better with Stryde than they do with Precice 2.2. I mean, I still think that they just do better. I mean, and you've had experience maybe talking to patients that have gone through this, and you can see, I mean, patients, they walk at 2 weeks, they lose their, walk by 2 or 3 weeks, they go back to work, they go back to doing stuff. So, I think the regenerates are more solid because they're weight bearing so much. I think the regenerate actually forms a little bit more robustly. So I do think there's large advantages of Stryde still over Precice 2.2. I mean, Precice 2.2 still accomplish the job in some sense, but you'll have to be restricted with weight bearing functionality and the rehabilitation component of it. But I still think that those advantages are quite good. I mean, I've seen them. I think it becomes more palatable also for patients to go through the procedure. I think that patients really don't lose as much as they thought they were, in going back to life. A lot of my patients return back to work, and so it's been really good from that perspective. So the fact that we had to pause on this for a little while is unfortunate, but I think it's rightfully done, and I think that we're going to look into it and kind of sort of try to solve the problem.
Yeah, definitely. Now, for the patients who had that hypertrophy, obviously bone remodels itself. How soon would you say that will it just remodel itself as a typical bone, or will it take longer because it has to kind of, that has a lot of bone regenerate? What do you think in that, in terms of that?
I think the bone will remodel. I think that once the implant is removed, even the regenerate models, like sometimes people form really robust regenerates. I've had some patients that are healthy or they eat a lot or something, and they form just regenerates. And even those patients will, that bone will model and thin out. And sometimes it may take some time. I think that for the small around the distal screw and maybe around the junctional area, and I don't think that it really causes any particular problem. I think that will probably model over the next 12 months plus to kind of bone sort of flatten out a little bit as it kind of goes. And I don't think it'll have much effect. I think once you take away the inciting factor, which is the implant itself, I think that change will certainly happen.
Okay, very cool. That's good to know because a lot of patients are like, well, is my bone going to look normal again? So that clears that up. Very cool. Dr. D, obviously you just mentioned the Precice tube nail being available, in the meanwhile, while the Stryde is getting its workaround to fix. Do you feel that you mentioned that you believe that although the Stryde has more advantages and benefits for the patients, and unfortunate that we have to take a little break from it, is the Precice 2 a good nail for those who want to get it done in the meanwhile?
Yeah, no, I mean, for the longest time, Precice was what was used, right? I mean, for a decade, having Stryde, Precice was used. I think certainly it's become more palatable that Stryde is available and patients can do a lot more. Well, yeah, Precice 2.2. If this time frame works the best for you, then it's certainly an option. I think where it, looking back, just looking at it and comparing it to Stryde, I would say, well, obviously, you'd be looking at 4 to 5 months where you're not weight bearing fully. You'd have to use some sort of either crutch or walker or something like that to offload the weight. The Precice 2.2, its largest size only takes 75 pounds per leg.
Okay.
So most patients, obviously. So you would, until you consolidate, you'd have to offload that weight during that entire phase. And if you're looking at a centimeter lengthening, you're looking at probably 4 to 5 months to kind of achieve that. The other thing is, maybe the regenerate may be slightly more robust in the Stryde patients. Bone response to mechanical stimulus. So if you can walk and do stuff and do more stuff, load the bone more, the regenerate, I believe, will be thicker and will be more dense and will probably consolidate a little faster.
Yeah, that's a great answer, and I think that a lot of patients are, trying to determine, is the time frame more beneficial than the benefits of the Stryde, and that's kind of your perspective. So I love that. I'm glad you gave that aspect there. So, Dr. D, I want to get your take on how NuVasive Specialized Orthopedics is handling the issue, because obviously you mentioned at the beginning this was a voluntary measure that they took to remove the nail off the market to do additional testing. So, do you feel it was a good call on the part of the company to do that? And when it does come back out, do you think that it will be safe to use the nail for patients, or is there going to be some sort of clinical beta testing or whatnot?
Sure. So I think I applaud NuVasive for taking the implant off and doing. I think they could have probably after speaking to the FDA, they probably could have done these testings and done these studies simultaneously with having the nail still on the market. But because what happened with the European Union and stuff, they I think felt that I think it'll look certainly much better than taking the responsible route, which I think is very fair to understand this a little bit more fully in detail and make sure there's really no clinical implications. So I think I applaud NuVasive from that perspective. I think they did a good job in trying to really cover all their bases and make sure that we're going to look at this and figure everything out and see if there is something that needs to be fixed, or if there is something that this is clinically acceptable in the sense of these changes happen in these implants and they should be taken out at 12 months, or they should be taken out within whatever the timeline is, 15 months, and so whatever that is. Don't forget, we used to do this with external fixers. You didn't have to explain to anyone the fixer had to come off. We didn't have to explain. It wasn't implied. I know that you don't feel the implant; it's inside, so you're thinking, "Oh, what I need to." But it's really the same conceptually. That it is approved as a temporary implant to put in in these areas to lengthen the tissue. And once its job is done, then it should be removed. Okay. So certainly, I think what they've done so far, and even with the testing and making sure that they're compliant with all those things, that I think they've done a great job with that. So, and just a side note, I'm a consultant for NuVasive as well. So just
right,
consultant. So that but I try to be obviously very give you what I think, regardless of that. So
transparent about it. Very cool, awesome, and yeah, so that was amazing. Really good giving your perspective on the whole Stryde nail removal. And I guess this is your chance to kind of just shout out to your fans and current patients and the patients who may want to kind of reach out to you in the meanwhile and take advantage of the time down while the Stryde is being worked on. And you can just kind of like give them some words of advice, or if they're considering waiting for the Stryde, this is your chance to kind of talk to them.
Yeah. So, well, thanks for that. So yeah, I mean, I think it's a little bit of a setback in some ways. I mean, I think there's some patients I've talked to that are certainly very disappointed, and so I just want to say, don't feel bad. I do think that this technology is going to come back. As a company, NuVasive certainly was really betting on this Biodur type material. They were actually going to phase out titanium altogether. Actually, go to Biodur because it's a superior thing. Why would you go with an implant that can't bear as much weight when you can have all these stainless steel, type Biodur type products. So, from a company perspective, it's a big part of their agenda to make sure that they know exactly what's going on and how to either change it or how to, understand it and know if it needs to be changed or not needs to be changed. So, I know that they're working very hard day and night on trying to get this sort of, sort of rectified. So, that's one, one little setback, but I don't want people to be discouraged. I've lost some patients who seemed like they were extremely discouraged about it. And I just want to tell them that, I think it's going to all be okay. It might be a, minor setback. And hopefully, we'll get some more data by the summer, and either we'll have we're back doing these types of cases with Stryde in late summer, or maybe potentially a little longer. But that's our current timeline right now. Okay. Not to be set back by it. I mean, I think the optics of it, maybe not the best. I think in some ways, and even for patients who talk more about this type of surgery from the cosmetic perspective. I mean, I think it, we like that. I mean, I think we like that people talk about it and people, converse about it, and there's more transparency around it. And just like with the technology, with the, with this type of implant, we want to have transparency around as well, what we're seeing, what changes we're seeing, and we want to be transparent with patients as well, so they have a good understanding of what's going on and what we're seeing. Not to alarm them, because I don't think it's alarming necessarily. I think it's to be expected that the changes in the metal itself, but know that we're seeing something, and then we're looking into it and seeing if we can kind of if it needs modification, or maybe it doesn't need modification. Maybe they just need to be explanted in the 12-month period, and we kind of move on from there. So I mean, that's kind of my main thing. I just don't want patients to feel discouraged, because I know we had to reschedule or cancel a lot of patients in March and April, and so I just want to let them know I think that it will come back, and I think the concept of what we do is certainly alive and well, and I think that it will continue to grow. And just like we have platforms like this, we have a lot more interest in from media and from other types of patients, and I think that this type of procedure reaches more people, and I do think it's life changing. I think for some patients, that's why we do what we do, right? I mean, it's life changing, and and we're going to continue to do that as best we can and as safely as we can. So that's what we're going to do.
Very good way to end it. Well, thank you so much, everyone. That is Dr. Kevin Debiparshad from the LimbplastX Institute in Las Vegas, Nevada. If you want to reach out to him, you can find his contact information in the show notes. Dr. D, thanks so much for coming on and sharing your perspective. I really appreciate it.
Right, great. And we're still doing our virtual and in-person consultations as well. If anyone would like to further converse with us, then I'm happy. All right.
Yep, definitely. I'll be sure to post all of that in the show notes. So thank you. All right. So there's Dr. Debiparshad's perspective of the situation, as well as the clinical relevance based on the data that he's found. Now, the Stryde nail is not available right now. However, the Precice 2 nail is. And so if you're interested in lengthening in the meanwhile, you can reach out to Dr. D by finding all of his contact information in the show notes. Until next time, this is Victor from Cyborg for Life, signing out.